Hello, thank you for watching this video. This is a presentation on catatonia. So we look at the following aspects of catatonia: historical background, clinical picture, differential diagnosis, how catatonia is included in ICD-10 and DSM-5, catatonia and neuroleptic malignant syndrome, investigations, rating scales for catatonia, treatment of catatonia, potential complications of catatonia and its prognosis, and possible underlying etiology of catatonia. Some information about myself. I'm a consultant psychiatrist from Chennai in India. I worked for many years in the United Kingdom. Some historical background about catatonia. Catatonia was first described in 1874 by Carl Ludwig Karlbaum. Emil Kraepelin recognized catatonia as a type of dementia praecox. Eugene Bleuler included it as a type of schizophrenia. Since antipsychotics were introduced about 50-60 years ago, catatonia is much less common. It still occurs, and research studies report rates of about 10% of acute admissions. But either because of reduced severity or because of lack of experience in the assessing clinician, the catatonia may be underdiagnosed. And the presentation of catatonia can be dramatic and might provoke anxiety in the treating psychiatrist or other physician. And catatonia can be both functional and organic, but by a simple systematic approach to assessment and treatment, catatonia can be appropriately detected and effectively managed. And the positive thing is that most patients respond well to treatment. This is a photo of a patient with catatonia from 1894. Catatonic stupor is one of the most dramatic presentations that you can see in psychiatry. And stupor is a combination of mutism and immobility. So the patient does not say anything and does not move. And when it occurs, it is clearly obvious. And posturing is another presentation of catatonia. The patient maintains his body in uncomfortable positions for long periods. In a non-catatonic person, such postures will be extremely painful and almost impossible to maintain for more than a few minutes. Catalepsy is an extreme form of posturing. And this is a picture of a patient who is exhibiting posturing. And another example. Waxy flexibility is another characteristic feature of catatonia. So in this, the psychiatrist or the examining physician can position the patient's body into uncomfortable postures. So the patient's body is flexible like wax that can be molded into different shapes. hence the name waxy-flexibility. And the difference from posturing is that waxy-flexibility is examiner-induced abnormal positioning, while posturing is self-induced abnormal positioning. And this is a photograph of a patient who is showing waxy-flexibility. So now we move on to automatic obedience. So in this, the patient automatically obeys the instructions of the psychiatrist like a robot. And mitmachen and mitgehen are forms of automatic obedience. So these are German words. And mitmachen is where, despite being told to resist, the patient allows the examiner to position his body. And in mitgehen, it's an extreme automatic obedience where just by touching, the examiner is able to move the patient's body. Negativism is the converse of automatic obedience. So the patient resists the attempts by the psychiatrist to move his body. Classically, the resistance offered by the patient is exactly opposite and equal to the strength applied by the examiner. The German term for negativism is Gegenhalten. Catatonic excitement refers to excessive motor activity that is purposeless and that is not influenced by external stimuli. So it is highly unpredictable. And during excitement, the patient can become violent. Some patients can suddenly alternate between stupor and excitement. In ambitendency, the patient alternates between cooperating with and resisting the examiner's instructions. So for example, when the examiner offers to shake the patient's hand, the patient alternatively extends and withdraws his hand. In obstruction, the patient suddenly stops while doing a particular action, and the patient is unable to give a reason. This appears to be the motor counterpart of thought block. Thought block is a phenomenon typically seen in schizophrenia, where the patient, while talking, suddenly stops, sometimes in mid-sentence, and there is a gap, and then the patient resumes from where he left. And when you ask the patient, he might say that there was a block in his thinking. Mannerisms and stereotypies can also be seen in catatonia. And mannerisms are repetitive goal-directed movements. For example, saluting, walking tiptoe, hopping, etc. While stereotypies are repetitive but not goal-directed movements. Example, rocking or repeatedly patting oneself. Both stereotypies and mannerisms are seen in non-catatonic states like chronic schizophrenia, autism, and developmental disability. In perseveration, the patient keeps doing an action that has lost its initial relevance. For example, the examiner offers his hand to shake. The patient shakes the hand, but then keeps offering his hand again and again. Speech abnormalities can also be seen in catatonia. In echolalia, the patient repeats what the examiner says. In logorrhea, the patient displays incessant and incoherent speech. Verbigeration is a form of verbal perseveration, and it includes logoclonia, where the patient keeps repeating certain syllables, and palilalia, where the patient keeps repeating certain words. And speech abnormalities are also not specific to catatonia, and they can occur more commonly in chronic schizophrenia, developmental disorders, Tourette syndrome, etc. And I have listed the catatonic signs in alphabetical order. In total, there are 27 signs, and there might be some overlap between some of these signs. Ambitendency, automatic obedience, aversion, catalepsy, echolalia, echopraxia, excitement, forced grasping, gegenhalten, grimacing, immobility, logorrhea, mannerisms, mitgehen, mitmachen, mutism, negativism, obstruction, perseveration, posturing, psychological pillow. So this is an interesting sign where the patient will be lying on the bed with their head raised as if there is a pillow in between their head and the bed. And this is a highly uncomfortable posture which the patient is able to maintain for prolonged periods. Rigidity, staring, stereotypies, stupor, verbigeration, and waxy flexibility. And some of these signs have German names because in modern psychiatry, a number of pioneers were from Germany. So we now move on to differential diagnosis. Catatonia can be functional, that is caused by a psychiatric illness, or organic, caused by a physical illness. In some cases, no particular cause can be identified, and it's called idiopathic catatonia. And within functional catatonia, there are several possibilities. Traditionally, catatonia has been linked to schizophrenia. However, it can be caused by other psychiatric disorders also. In fact, catatonia is more commonly seen in mood disorders than in schizophrenia. And by mood disorders, we refer to depression and mania. So, functional catatonia can be caused by affective or mood disorders such as bipolar disorder and unipolar depression, schizophrenia, schizoaffective disorder, postpartum psychosis, abrupt withdrawal of clozapine, catatonia can sometimes be due to dissociative disorder, in which case it is called hysterical or dissociative stupor. And the possible organic causes of catatonia include dementia, infections such as delirium, meningitis, encephalitis, temporal lobe epilepsy, drug abuse or withdrawal, for example, cocaine. Sometimes prescribed drugs can cause catatonia, ciprofloxacin, an antibiotic, amiodarone, an antiarrhythmic. I recently had a patient who developed catatonic depression after being started on amiodarone. Metabolic causes include hyponatremia and Wilson's disease, which is a disorder of copper metabolism. Autoimmune disorders such as systemic lupus erythematosus. What are the potential risk factors for developing catatonia? History of brain injury, increasing age, especially in depression. So elderly depressed patients are more likely to present with catatonia than young patients with depression. Physical illness co-occurring at the time of onset of psychosis. History of severe childhood infectious diseases such as rheumatic fever, thrombotic thrombocytopenic purpura, which is a disorder of platelets. So we'll now move on to how catatonia is presented in the psychiatric classification systems, namely ICD-10 and DSM-5. In ICD-10, there is a subtype of schizophrenia called catatonic schizophrenia, and I have included the criteria on the slide. In mood disorders in ICD-10, there is no separate category for catatonia. But if a patient with either depression or mania displays catatonic stupor, then the diagnosis becomes depressive episode with psychotic symptoms or mania with psychotic symptoms, even if there are no psychotic symptoms like delusions or hallucinations. Other ICD-10 categories that include catatonia include organic catatonic disorder and dissociative stupor. And in DSM-5, catatonia is defined as the presence of 3 or more out of 12 clinical features. So I've listed 6 of them in this slide. You can pause if you want to note them down. And these are the other 6. And DSM-5 also allows you to specify the underlying cause of catatonia, which might be one of the following that I have listed on this slide. Regarding types of catatonia, different classifications have been proposed. The basic classification is organic versus functional, and it can also be classified based on the underlying diagnosis. So autistic catatonia occurring in autism, and ictal catatonia seen in epilepsy. And Taylor and Fink have proposed this classification, where they divide catatonia into non-malignant, delirious, and malignant subtypes. And non-malignant catatonia is the classical catatonia. Delirious catatonia is delirious mania, while malignant catatonia includes lethal catatonia, neuroleptic malignant syndrome, and serotonin syndrome. Another classification that has been proposed divides catatonia into non-malignant and malignant, and each is then subdivided into retarded and excited subtypes. And there is a German classification of catatonia which divides catatonia into systematic and periodic subtypes. And just as we use rating scales for disorders like depression or obsessive compulsive disorder, there are rating scales for catatonia also. The most commonly used is the Bush-Francis catatonia rating scale. Another scale that is used is the modified Rogers scale. And rating scales are useful in checking for catatonic signs in suspected patients systematically and for monitoring progress and response to treatment. But a disadvantage is that the presence of non-specific signs may lead to an overdiagnosis of catatonia. Let us look at the Bush-Francis catatonia rating scale. So this has 23 items. Each item is rated on a scale of 0 to 3, and there is also a 14-item screening version. And there is also one item for assessing autonomic instability. Let us look at some sample items in the Bush-Francis catatonia rating scales. So to check for automatic obedience, the examiner reaches into his pocket and says, "Put out your tongue, I want to stick a pin in it." And if the patient has automatic obedience, he would indeed put out his tongue. And to check for ambitendency, the examiner extends his hand saying, "Do not shake my hand." And the typical catatonic response would be the patient alternating between offering his hand and withdrawing his hand, because the patient gets confused by the examiner extending his hand but at the same time saying not to shake his hand. To check for echopraxia, the examiner scratches his head in an exaggerated manner. Echopraxia refers to the phenomenon where the patient mimics the actions of the examiner. So in this case, if the patient has echopraxia, he would also scratch his head in an exaggerated manner. And to check for Mitgehen, which is a form of automatic obedience, ask the patient to extend the arm, place just one finger beneath and try to raise it slowly, saying, "Do not let me raise your arm." But because the patient shows automatic obedience, he would allow you to raise his arm with just the pressure of one finger, and the so-called angle poise slamp arm is seen if it is positive. So this is the angle poise lamp. So if the arm assumes that posture, it shows that the patient is exhibiting automatic obedience. Mitgehen. Now let us look at catatonia and neuroleptic malignant syndrome. NMS is a potentially life-threatening side effect of antipsychotics, whereas catatonia is a well-recognized risk factor for developing neuroleptic malignant syndrome. So it is generally recommended that antipsychotics should be avoided in the catatonic phase, even if the cause of the catatonia is a psychosis, because you do not want the patient to be at a higher risk of developing neuroleptic malignant syndrome. Atypical antipsychotics may have less risk of inducing neuroleptic malignant syndrome, but it is better to avoid them also if possible. Some experts consider that catatonia and NMS lie on the same spectrum because they share similar clinical features and they show a response to similar treatments. So they suggest that neuroleptic malignant syndrome should be regarded as a severe form of catatonia. In general, however, catatonia usually occurs when the patient is not taking antipsychotics, whereas neuroleptic malignant syndrome occurs after the administration of antipsychotics. In neuroleptic malignant syndrome, there is elevation of creatine phosphokinase and the total white cell count. What are the investigations to be done in a patient with catatonia? The main purpose is to try to establish whether the catatonia is functional or organic. A thorough history, usually from an informer, a mental state examination and physical examination are all important. Depending on the history and examination, the patient would need to be admitted either to a psychiatric or a medical ward. So the first line investigations would include a complete blood count, renal function tests, liver function, thyroid function, blood glucose, and creatine phosphokinase. Further investigations can include ECG, chest X-ray, CT or MRI of the brain, EEG, urine, blood culture, syphilis, HIV testing, autoantibody screening, heavy metal screening, and lumbar puncture. The treatment of catatonia. Historically, there were no effective treatments till the 1930s. And from the 1930s, various treatments were tried, including sodium amobarbital injection, inducing seizures by camphor oil injection or pentylene tetrazole injection, and these days majority of patients respond to benzodiazepines, and patients not responding or only partially responding to benzodiazepines can be effectively treated with ECT or electroconvulsive therapy. In organic catatonia, the treatment obviously has to involve addressing the underlying cause of catatonia. However, even in these patients, benzodiazepines and or ECT can be useful. Among benzodiazepines, lorazepam tends to be the drug of choice as it has the strongest evidence base from case reports. It can be given orally or intramuscularly. Diazepam orally or by intravenous infusion is another option. Response to benzodiazepines can be immediate and dramatic. Response to both benzodiazepines and electroconvulsive therapy is less if schizophrenia is the underlying cause of the catatonia. Although antipsychotics are not recommended in the acute catatonic phase, they may have a role in those patients who only show partial improvement with benzodiazepines and ECT. Atypical antipsychotics such as quetiapine are generally preferred in such cases. Other treatment options include carbamazepine, NMDA receptor antagonists like amantadine and memantine, lithium, and the sleeping tablet zolpidem. What are the symptoms of neuroleptic malignant syndrome? Clouding of consciousness, fever, rigidity, and autonomic instability. Depending on its severity, it is either managed on a general medical ward or in the intensive care unit. The main risk in NMS is renal failure due to rhabdomyolysis and myoglobinuria. So rhabdomyolysis refers to breakdown of muscle tissue, and myoglobinuria refers to excretion of the muscle protein myoglobin in urine. Treatment options for NMS include supportive measures such as rehydration, antipyretic, vital signs monitoring, etc. Benzodiazepines, muscle relaxant dantrolene, dopamine agonist bromocriptine can also be given. ECT can be an option for severe treatment resistant patients. What is the prognosis of catatonia? The prognosis of the acute phase is generally good. Long-term prognosis would depend on the underlying diagnosis. Catatonia can recur during future episodes of the illness. So a patient with a previous history of catatonia during a psychotic episode may be at increased risk of developing catatonia during future psychotic relapses also. In catatonia that frequently recurs, maintenance benzodiazepines or maintenance ECT can be considered. What are the complications of catatonia? In prolonged stupor, where the patient becomes dehydrated and continues to be immobile, there is increased risk of deep vein thrombosis and pulmonary embolism, which can lead to sudden death. In catatonic excitement, the patient can behave unpredictably and cause harm to oneself or to others or to their environment, such as the property of the ward where they are a patient. What is the underlying etiology of catatonia? The exact etiology is not known, as is the case with many psychiatric and medical disorders. One possible explanation is that there is deficiency of GABA, which is the main inhibitory neurotransmitter in the brain. This may explain why benzodiazepines, which increase the effect of GABA, help in catatonia. Another possible etiology could be excess of glutamate, which is the main excitatory neurotransmitter in the brain. This may explain why drugs like amantadine and memantine, which reduce the effect of glutamate, may be beneficial. Another possibility is the sudden massive blockade of dopamine receptors. Antipsychotics which block dopamine receptors are not useful in catatonia. There are many similarities, as we saw earlier, between catatonia and neuroleptic malignant syndrome, which is also caused by sudden massive blockade of dopamine receptors. Antipsychotics which block dopamine can precipitate neuroleptic malignant syndrome in catatonia by aggravating the dopamine blockade. And catatonia is seen in Lewy body dementia, where there is less dopamine already. So all these factors support the hypothesis that sudden massive blockade of dopamine receptors plays a role in catatonia. Before ending, I'll mention about a recent published case series. This was a study done in Taiwan. So they report 12 patients with catatonia over 9 years. I think this also highlights how infrequent classical catatonia has become, because to get 12 patients, they had to wait for 9 years. And the underlying diagnosis in all these patients was mood disorder, either unipolar depression or bipolar disorder. And the first treatment option they used was 2 milligrams of IM lorazepam, and the second option was an extra 2 milligram of IM lorazepam after 2 hours if the first option was not effective. And they exercised a third option of 10 milligrams of intravenous diazepam in 500 ml of normal saline if the patient did not respond to the second option also. What did they find? 8 out of the 12 patients responded to just one dose of 2 milligram of IM lorazepam. 2 out of the other 4 responded to the second injection of lorazepam, while the remaining 2 responded to the intravenous diazepam. So all patients responded to treatment, and all of them responded within 24 hours, which is quite remarkable when you consider how dramatic the catatonic presentation can be. I wanted to highlight this case series just to instill hope in the treating psychiatrist or physician that even if the presentation of catatonia can be quite alarming, it is eminently treatable. Just a few final points. In summary, catatonia, though it is much less common than before, still occurs. It can be recognized by systematic assessment and examination. Catatonia responds well to benzodiazepines and or ECT. Organic causes need to be borne in mind, particularly in treatment-resistant cases. Potential risks to the physical health of the patient and the potential risk to others need to be considered in severe cases of stupor or excitement. So we will finish by going through 5 multiple choice questions. The first question is, catatonia was first described by Schneider, Bloiler, Karlbaum or Kraepelin. If you want, you can pause now, and the answer is Karlbaum. Question 2. Which of the following is a recognized complication of catatonic stupor? Is it myocardial infarction, pulmonary embolism, or stroke? If you want, you can pause now. And the correct answer is B, pulmonary embolism. Question 3. Choose the correct option. Catatonic excitement is usually uninfluenced by external stimuli. Mid-Gehen and mid-Mahan are types of catatonic posturing. Mannerisms are repetitive, non-goal directed movements. You can pause now if you want. And the correct answer is A. Catatonic excitement is usually uninfluenced by external stimuli. Option B is wrong because these are types of automatic obedience. And option C is wrong because mannerisms are goal-directed movements. Question 4. Choose the correct option. If a catatonic patient refuses oral antipsychotic medication, it should be given by depot IM injection. If a catatonic patient refuses oral benzodiazepine, it should be given by IM or IV. Option C. Informed written consent should be obtained before treating a patient with catatonia. Which is the correct option? If you want, you can pause now. The correct answer is option B. Option A is wrong because you generally do not give antipsychotic medication to a catatonic patient, and you certainly will not give a long-acting depot injection. Option C is wrong because a patient in catatonic stupor would not be in a position to give informed written consent. Question 5. In neuroleptic malignant syndrome, the main risk is it A. renal failure, B. hepatic failure, C. cardiac failure, or D. disseminated intravascular coagulation? And the correct answer is A. renal failure because of rhabdomyolysis and myoglobinuria. We have now come to the end of this lecture. Hope you found this presentation useful. Thank you for listening.